Recording, so we're going to look at some case studies here. So I'm going to bring up the chat so I can see what you guys are saying to me. Here's the chat. All right, so we're going to start looking at this. Can everyone see the case study that I brought up? Oh, that made it way too big. Do I have a, can everyone see it at least on the screen? Spinal cord injury case study? Somebody nod and say yes. Okay, thank you. All right. So we're looking at right now, I'm just going to kind of go down through the history and the examination, then we're going to look at the examination. So we got a patient here who's a 19-year-old male admitted to the emergency department following a spinal cord injury, sustained while working. Going back to your knowledge of the etiology and the epidemiology of spinal cord injury patients, what is the likely demographic of this person? You've already got that he's 19. What ethnicity is probably? Yeah, more than likely white male. You're exactly correct, because that's about a good heavy 50% of the people that are there, right? So a patient was working in a warehouse moving wooden boards when approximately 200 pounds of lumber fell on him, resulting in immediate loss of lower extremity sensory and motor function. He sustained a flexion distraction injury at L1 vertebral body posteriorly with a near complete subluxation at T12. He also sustained spinous process fractures at T12 and L2. No loss of consciousness, no chest, neck, head, or abdominal injuries. All right. So looking at this one already, yeah, 250 pounds, wow, that'd be first. I was gonna say, first thing first, 250 pounds, ouch, right? Second, he has a lumbar fracture. How likely is that? Is that a likely fracture? Like, is that a common fracture? No, right? That's one of the least common fractures. I'm gonna move you guys over here. One of the least common fractures we can get, right? L's and the S's are kind of the least common. That doesn't mean that, so here's interesting. The L's and the S's are the least commonly fractured vertebrae, but it's also the most common complaint area for pain. Does that make sense? Because one of the number one thing I would be willing to say, if you go to an outpatient clinic, I'm going to say at least 50% of your patients will come in with lumbago, low back pain. I don't say it's 50%. It probably is. Feels like it sometimes. Feels like it's like 90% some days, right? So he has a flexion distraction, right? So that means he went which way, forwards or back? Yeah, flexion forwards. Okay, good. I just want, this is why I'm waking you guys up a little bit here. So he's kind of hunched over like this, right? And we know he has so subluxation at T12. What does that mean? Sometimes I'm like, this is a trick question. No, some days it's just a McKeever question, just seeing if you're awake. So subluxation at T12, what does that mean? Yes, this, yeah, right? T12 is loose, exactly. So remember that when we have, you know, this would be a full kind of dislocation. Subluxation looks like this, right? It kind of shifted. So what's one of the goals they're going to have to do in the hospital with that subluxation? They're going to have to distract, yeah, unsublux, exactly. They're going to have to distract it and realign it, right? So they're going to have to put some traction on to pull those bones apart and then put some alignments in to align those bones back up, because they're not going to be able to fix anything until they fix that, right? And he's also got a spinous fracture, spinous process fracture at T12 and L2. Are we really worried about that? Is that like life-threatening? Let's go that way. Yeah, no, it's not a good job, right? It's not a life-threatening. What does that compromise, though, at T12 and L2? It doesn't compromise too much. It compromises structural integrity, right? Because now those spinous processes that are sitting on top of each other Because remember, when you go down, the spinal processes kind of wrap down over each other, right? Now those spinous processes are snapped off. So you might have some areas where it's even easier for a subluxation to happen, right? And that's probably why that T12 subluxation happened, is because that spinous process snapped clean off, and now it's easy to slide back and fall off, right? So no loss of consciousness, no chest, head, neck, or abdominal injuries. I don't know how he accomplished that, but that's pretty darn impressive to me, right? The only thing I can figure out is the stuff fell on him like this, and he flexed forward, and that's how he got the injury, right? It kind of flipped, kind of sandwiched him. So good, no head, check, neck, or chest injury. All right, L1, T12 kind of injury. Are we worried about autonomic dysreflexia? Are we, let's put it this way. Is this a high rate of autonomic dysreflexia at this level? Yeah, no, it's not a high rate, right? But it still can happen. Oh, good. See, autonomic dysreflexia. If I say that word, that phrase, what should you remember again? What should you say? If I say autonomic dysreflexia, you say hyperreflexia. Good. What should automatically pop into your brain as soon as you hear autonomic dysreflexia? Stand them up, check the catheter. Good. Right? Stand them up, check the catheter. That's the disease where the catheter, one of the catheters has become kinked, and it's sending their autonomic nervous system into hyperdrive because fluid, fecal matter, or whatever it is, a blockage in the artery, wherever that, whatever catheter is that's blocking up, is getting back pressure, right? You know, literally that if you have a urinary catheter that's pinched off or pinched, it can back up all the way back to the kidneys. And the body is saying something's wrong, flashing lights, right? So a patient presents very, very diaphoretic, very sweaty, right? They start getting goose flesh, right? They're getting all kinds of nice pimply stuff all over their skin. They start shaking. They complain of a headache. Their blood pressure goes through the roof, and it's usually 40 millimeters of mercury change, right? They start feeling a little bit sense of doom and gloom. We're like, oh, something's wrong. I don't feel right. Something's not right, right? That's a sign of autonomic dysreflexia if you have a spinal cord injury. Now, that can happen to anyone, right? And I told you guys have all experienced a little bit of autonomic dysreflexia if you've ever driven in a car and held your bladder, right? Driving in the car going, I am not stopping till I get through Barstow because I am not going to the bathroom in Barstow. And you squeeze down on your bladder. It's like, yep. You squeeze down on that bladder and you're like, I am not going it, right? And you get about 20 miles down the road and you're starting to get the sweat beads going down your forehead. Good. It helps you remember it, right? That sweat bead starts forming, and then all of a sudden your bowels are like, hey, you know, not only is the bladder half empty, but so do I, right? That's kind of that autonomic dysreflexia. So remember, that is, you can have it as a high risk is T5 and above, but down to T10 is common. It doesn't mean that this patient couldn't get it. It just means it's not as common at this level. So prior level of injury, past medical history, no prior history really. So basically, what they would normally put there is not none prior to injury. What they would probably put is unremarkable, right? Unremarkable means there's nothing to say, right? Like if you were to put on your soap note, patient's vitals are unremarkable. That means that pretty much all the vitals you took are what? Normal. They're within the normal limits. Yeah, they're good. All right, so surgical history from the ED, right? And just please, ED does not mean erectile dysfunction. I know somebody's going to laugh, but I've had a student say that to me before. That's not what the commercial says exactly, right? ED is emergency department. So we're calling the emergency area now. It used to be the emergency room. It's now the emergency department. So the patient was taken to the operating room for a laminectomy at T12 to L1. Arthrodesis of T11 to L4. Okay, so let's deal with the first one. Laminectomy, T12 to L1. Why did they do a laminectomy? What are they trying to reduce compression on? Yeah, relieve pressure on what? The nerve roots. Good. And maybe the disc too a little bit. It could be the disc is shifted too, Jairus. So it's not necessarily that's wrong, but it's more the nerve roots probably be a better option there. Now, arthrodesis, T11 to L4. What does that tell you? What is an arthrodesis? I'll give you a hint. I have an arthrodesis, joint fusion. Yeah. So he's fused T11 to L4. That's okay. This is why we're going over this. This is why I would do this. It's okay. It's okay to make mistakes. So they did pedicle screw fixation at T11 to L4 bilaterally. So you remember that picture I showed you guys of those screws? Desis is fusion, splitting. Are you talking ectomy? Lysis is blowing apart. Lysis is death. Are you talking about lethesis? We'll figure it out. It's okay. Just think about it for a second. Maybe I can figure out. No, that's fine. Think about it for a little bit. Maybe we'll figure out what you kind of mean in there. So pedicle screw fixation, meaning they put probably their rods or they put bony fusions the whole way down from L1 or T11, T12, L1, L2, L3, L4. All right, so let's think about it. What's his lumbar flexion like now? Yeah, almost non-existent. It's a really good term for it. Good, Jara, right? Most of his flexion is going to be up in the T's now, right? So that spine. So just imagine if you put a brace on, kind of, so belly button's about T10, right? Or right? So about there, you're fused from there to about that little dimples on your back. That's all fused. So you only have flexion up here, above your belly button, kind of. That's a good chunk of your spine knocked out, right? Durotomy repair with muscle patch. What does that tell you got injured as well? And this is we're going high level here, guys. So this is not something like, don't think this is easy stuff we're talking about. Durotomy. What's a durotomy? It says it in the name. Dura matter, good, right? Otomy meaning what? If you have an ostomy bag. Yeah, right? They cut into it. There's probably a tear there, so they cut into it, and probably, I'm looking at this, I'm not too familiar with a durotomy repair, but they probably took part of the spinal muscles and used that to seal the tear. Because it's not going to need the spinal muscles in that area pretty much at this point. Posterior lateral fusion with allograft. Allograft meaning what? Let's talk about the grafts again, right? And not like graft in. This is the grafts. Autograft is what? Same person, good, right? So an autograft, so for example, my posterior fusion has autografts in it. They took my two spinous processes, cut them off, and used those as fusion. The allo is the same species, right? So we got a donor somewhere, right? 11 days after admission, he was transferred to rehab. So he's he went pretty quick. I hate to say, for that bad of a spinal cord injury patient, he must be motivated. Because 11 days, with that level, less than 2 weeks. Yeah. And he's young. And it seems like he's pretty good health, right? Or it's just that they couldn't get any more money out of him, so they shipped him off. But again, with most patients, at day 4, hospitals start losing money. At about day 4 of inpatient admission. So that's why you're going to see a lot of hospitals try to get people out post-op day 3. Because post-op day 3, they know that they get to that day 4, they're going to start losing money. Now, this patient, they probably could still get some money out of, but... All right, so let's look at his social history here. He's a social drinker. Very social. No, just kidding. The patient is the eldest of 5 children. He has 4 younger brothers. He also has a girlfriend who is pregnant. He was employed as a router in a warehouse where he acquired the injury. All right. Well, could be. Yeah, absolutely. Anthony asked, can the painkillers help the recovery process so he doesn't feel pain as much? Maybe. You're exactly right, Anthony. He may be completely whopped out on painkillers. And so he's like, I'm ready. Let's go. And we start weaning him off the painkillers. He comes to the biggest baby in the world. It's possible. All right, so we got some social history here. Does this really help us too much? The only thing we know there is what? He potentially has what at home? He may have some help, right? We don't know where the brothers are, though, do we? Yeah, we don't know where the brothers are. We don't know what their ages are. But just from those of you that might have kids, do you think this kid's competitive? Yeah, he probably does lift a lot. You're right, right? Yeah, he's the eldest of 5 children. He's pretty competitive. I'm betting he's probably pretty competitive. Right? That's just, I mean, you have 5 kids. The kids got to fend for themselves, right? And he worked at a warehouse, so I mean, he probably worked his way up from just general picker to a router, which means he's probably done a lot of manual labor. I see one thing that's a concern to me in the social history. What's my concern, do you think? Looking at the social history, what do you think my concern is? The pregnant girl. Yeah. Because she's going to want to help him. Right? At least maybe. I mean, I don't know how long they've been together. She's going to want to, I'm just hoping the best in her and hoping that she's going to want to help him, that she's not going to cut bait and run as soon as she hears spinal cord injury. And you'll be amazed at how often that actually happens in the hospital. Literally, you know, somebody comes in, they've got a stroke, they've got a spinal cord injury now. They're like, yeah, I've been married for 5 years, but my wife's not coming to see me. It is sad. You're exactly right. But, and then you call up the wife and it's like, that number has been disconnected and is no longer in service. All right, here's what we need right here. Here's the stuff we need to know as PTAs. Living environment. Ding dong, somebody else just joined us. I don't know who that was. Let's see who that was. Yeah, no one I have to be worried about. Making sure it wasn't somebody that shouldn't be in here. Gosh darn it, I keep hoping to have a Zoom bomb by somebody famous, but no one's Zoom bombing me.
I was just switching from my phone to my computer.
Oh, that's okay, I'm just picking on you, that's all. The patient has been living in an apartment, but recently moved back with his parents a few months ago. Is that a positive? That gives me a little hope. Yeah, that gives me a little hope. Currently lives with his parents and 4 younger brothers. Good Lord. His girlfriend plans to move into the family home following his discharge. The family lives in a small 1-story rental home with a single step to enter. They plan to move soon to better accommodate the family size and for potential modifications to improve accessibility. Patient's mother states she's available for 24-hour care if needed. Patient's mother and girlfriend were immediately involved in care prior to or post-injury. So as a PTA, I'm looking at this going, okay, this kid's got it. Honestly, I'm really looking at this going, okay, this kid's got some care here, right? I mean, no stairs at home, except for that one step to enter. Can we take care of one step pretty easily? Yeah, we can make a ramp, you know, one step, 8 inches means they have to make how big of a ramp again? Say the step is 8 inches high. How long does the ramp have to be? 8 feet, very good, right? Remember, for every inch you go up, it's 1 foot out. For every 1 inch of rise, 1 foot of run, right? So 8-foot ramp, that's actually pretty easy to build. Honestly, you can just go get 8 feet of, you know, MDF or something to that effect and make a ramp pretty easy. And he's got 4 brothers who can start working on it. So prior level function, completely independent. We shouldn't have to guess that one. So let's look at his chief complaints here. Patient was admitted for rehabilitation 11 days after the accident. Initial examination indicated a T12 spinal cord injury. Okay. So T12 spinal cord injury. That gives us his neurological level. What was the neurological level again? What is the neurological level with spinal cord injury patients again? Because this might come up as a question on your test. Well, no, it says here, it says he's T12. That means that's his neurological level. But what does that mean? What does a T12 neurological level mean? I think you guys are thinking through this way too hard. Remember, neurological level is the area of the spinal cord that has full motor and full sensory bilaterally. So he's a T12 SCI. So that means he's got full motor and spinal cord from T12 and up. Is that pretty good? I mean, he doesn't have legs, right? We lost the legs. That sucks. But do we have some trunk control? Yeah, we got some trunk control, right? We've got full upper extremities. You know, in the grand scheme of things, this guy kind of won the spinal cord lottery. I hate to say it. I mean, yeah, it's gonna hurt him that he lost his legs, but this could be a lot worse, right? So using the Asia classification, blah, 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 blah. The lesion was designated as a category A complete injury. And it says there, no motor or sensory function is preserved in the sacral segments. How did they test the sacral segments? What are those 2 tests they performed? The anal sphincter reflex, good. The Brown reflex, the Brown wink test. Anal sphincter and the bulbocavernosus reflex, good. The BCR, the BSR, right? Depending upon if you're dealing with male or female. So he's got no motor or sensory in the bowel and bladder. So how is he going to pee and poop? Because he can't control it. He's probably going to be cathed for urinary. And yeah, well, they may not have to do they might have to do an ostomy bag. Because if he has full bowel, if his bowels are functional, he just can't poop, then they're just going to be putting him in a brief. Which means he's going to be pooping himself. Do you think that's going to affect his... They may for a little while. Adrian asked me doing all liquid diet. That's going to depend upon what the, especially if they need to clean anything out for testing the bowels, they probably will. Because they need to see how far up he might have some damage on those bowels. Because, you know, if he's got most of his, descending colon knocked out from the spinal cord injury, then he may have to have an ostomy bag put in. Right? But if he's got full, muscular contraction of that descending colon, and the only thing that's happening is that anal sphincter has no closing ability, that just means as he eats, the stuff's just going to come out. And that's usually what's going to happen most times when I see them in the hospital is they'll usually poop after eating, because that's the way the body's kind of designed, right? You take in something, the body expels something, right? And if you actually get on a really kind of regular diet, you'll find that happens to even you guys, that, eat something, all of a sudden it's time to clean out the bowels a little bit. You didn't think we'd be talking about this today, did you? Patient has a neurogenic bladder, and it says requires intermittent catheterization. Ooh, here, we've got some problem. Manual bowel evacuation. Now, this might be a reason we put him on an all-liquid diet here, Adrian. It says manual bowel evacuation. What does that mean? What does a manual bowel evacuation have to mean? It's exactly like it probably sounds to you guys. Somebody has to do it. Put some gloves on and dig them out. Why do you think, Pray, why do you think he's probably not able to poop? I think Anthony had mentioned it earlier. What's probably causing him to not be able to poop? Meds and not moving, right? Both those combined. Yeah, his bowel is probably concrete. All right, he's currently has a thoracolumbo-sacral orthosis, TLSO, to be worn out of bed. This is a common thing. Even if you guys get nothing else from me about orthotics this semester, really, almost all of your orthotic orders are going to say OOB. That means out of bed. So if your patient is out of bed to the chair, they have to have their orthotic on. If they're out of bed to go for a walk, they have to have their orthotic on. If they're out of bed to go poop, they've got to have their orthotic on. Right? And the TLSO is that kind of clamshell brace that'll support him from the thoracic region, lumbar region, and sacral region to give him some support. Right? Or when he's more than 45 degrees and angle in bed, and that's because he's lost some spinal processes, but that's beside the point. All right, so we can read through all this here, but one of the things I noticed here, I think this is really unrealistic. I think they messed that up. If he's 6'1" and 127 pounds, man, he's tiny. I mean, on a positive note, that's good to be good for transfers, right? But I just, I have a hard time believing that one. I think that should be 227, maybe not 127. May explain how they got folded exactly. All right, so just looking brief through this, manual muscle strength in his legs, 0 out of 5. So he's got nothing in his legs. So here's that Asia assessment here, right? So remember, we have it here, 0 is absent, 1 is altered, 2 is normal. If you get down to T12, if you look across there, all those at T12 are 2. You get down to L1, he's down to 1. That means he's got to be a T12 neuro level, right? So I'm not going to go through this totally at this point. We know he's complete already. What I want to do is let me bring up the video quick on this. Let's look at neuromuscular real quick. Cranial nerves 1 through 12 intact. Well, that kind of makes sense, doesn't it? If he had a cranial nerve injury with this, I'd be a little concerned. Didn't get any head to head, right? So he has intact light touch down to L1. No sensation of deep anal pressure or pinprick, no voluntary anal contraction, tingling sensation with light touch from L1 to L4, L5. So he's got some sensation there. Do you remember what the term for those areas that he has some sensation below his neurological level is called? He has a zone where he still has some feeling. Partial. And the area is saved, so preservation. So he's got some partial preservation. DTR's normal in the upper extremities, 0 out of 2 in the lower extremities. G, right? Wonder why. Let's look at his pain here real quick. Patient reports moderate pain in low back at rest, 6 out of 10, and severe pain in hips at end range passive hip flexion. Well, gee, I wonder why. Because anytime you're flexing his hips, straight leg raising, or abducting his hip, it's putting pressure on that area where he's got the fractures. So he's not liking it, right? All right, so let's look at this video real quick. Let me stop share and swap over this video. This should be the first one I need to see. All right, where did my Zoom go? There's my Zoom. Share screen. All right. Let's take a look at this video quick.
The patient is a 19-year-old male initially presenting with a T12 complete spinal cord injury, which later presented as a T12 incomplete injury. The patient transfers with a sliding board and minimum assistance. He requires verbal cueing for proper hand placement and is dependent on the therapist to reposition his lower extremities.
He does look under 27 pounds, doesn't he? Now that we look at it. Thank you, Renee. I didn't look at the video before he came in here. All right, what do you think my big complaint's going to be here? Before we go any further in this video. Posture, okay, that'll be a big complaint too. Gait belt. Yep. How's he going to save him if this kid goes down? He's going to have to grab him, right? I also don't necessarily want to be on a rolling stool when doing this. Grabbing the brace, exactly. It might be the best thing he's going to be able to do. You know, rolling stool doesn't give me a lot of stability, does it? I mean, you could. I just don't know that I would be with a spinal cord injury. I'd probably be up on my legs kind of squatting down because I'd rather have that. I'd rather take a little bit of pain on my quads than potential for sliding out of the way. But his posture is horrible too.
He displays trunk instability and poor directional translation while scooting.
I'll talk about that in a second, Anthony.
He is instructed to use the head-hips relationship by leaning anterior and in the opposite direction he intends to move. Fear of falling forward is very common when initially learning this technique. The patient transitions from a posterior tripod position to an anterior tripod position with supervision. He shifts his hands from his sides to his lap and then raised for unsupported sitting. The thoracolumbo-sacral orthosis and the low level of injury are two factors that contribute to increased stability of unsupported sitting balance. To transition from sitting to supine, the patient uses his upper extremities to manage his lower extremities. While stabilizing with one arm, the other is used to grasp behind the knee and lift upward and onto the mat while simultaneously transitioning onto the elbow. The therapist provides minimal assistance at the distal lower extremity.
Grab this leg. We'll do the same thing. Pulling it over and across. Bring your left arm up more.
The patient requires minimal posterior support to elevate onto extended upper extremities. He expresses pain in long sitting secondary to hamstring tightness.
Go ahead and push all the way forward.
To relieve this, the knees are flexed to a frog sitting position. He then attempts to reach forward to grasp his lower extremities and slide toward the edge of the mat. He has difficulty leaning anteriorly, expressing complaints of severe pain in the lower back and hips.
and square your body up the rest of the way.
Okay. So we're gonna watch all 3 of these videos real quick, and then we'll talk through it. But that car is called a simu car. It's not a real car, obviously. You can see that kind of was cut off in the front. But that's a car that OT will use to, and we can actually use it. I use the simu cars a lot, actually, especially when I know I'm sending a patient home that may have been a total hip replacement or a total knee replacement. I'm not teaching them to get in the driver's seat. I'm just teaching them how to get in and out of a car. That should be something, honestly, yeah, it is really cool, right? It's really nice when you have those in the hospital. If you don't have a simu car, what can you do? Video games. But I'm saying with actually transfer, yeah, go get a real car. Have the patient's family bring their real car down to the main lobby area and help them work on getting in and out of that car. Because a big mistake I've seen before, and I had this, where the PTA that was working all week with the patient was working on car transfers in one of those simu cars. And then I went to discharge the patient, and the dad comes to pick him up in a brodozer. Does everyone know what a brodozer is? Yeah, it's a truck that's got 28 inches of lift and has never seen off-road ever, right? That's why I call them brodozers. So the patient had never transferred into one of those. This is kind of important to understand. That's a question that's kind of important to ask. What kind of vehicle are you going home in? The other thing was that patient was actually a cardiac patient. So he had open heart surgery. And the truck that his dad was driving home in had airbags. So guess what that meant? He couldn't go home. Because this was before Uber and all that. Because the patient with the chest surgery can't get in the front seat of a car unless the airbags can be turned off. And this was an old brodozer. But yeah, simu cars are pretty cool if you have them. All right, so now we've kind of looked at that. So let's see. I think this is the treatment, if I remember correctly.
It is 4 weeks since evaluation, and the patient is engaged in transfer training. He requires minimal assistance with maintaining the proper head-hips relationship and...
Was that a big difference in his transfer? Yeah, huge difference.
...is independent in positioning the lower extremities. His pre-injury upper extremity strength and small frame aid his ability to achieve sufficient elevation with this technique.
Yay, he's got a gait belt on him. Kelly,
the patient continues to work on bed mobility, requiring only occasional verbal cues from the therapist for improved technique.
Okay, hold on here. What assistance level is he right now? What assistance level is the therapist providing right now? Not standby. Close. What's the other one that goes along with supervision? There we go. He's just giving him cueing. Right? If he was standby, he'd have to literally be doing what? Standing by him. Right? Close to the touch. So supervision's where I'm back like that. I'm like, okay, Daniel, or whatever your name is, show me what you got. Right? And I'm just able to give him verbal cues. That would be a supervision.
To improve core strength and balance, the patient elevates a weighted plastic pipe overhead. The higher the pipe is raised, the more difficult it is to maintain stability.
I think he's actually lost some weight.
The patient practices dynamic sitting balance by throwing and catching weighted balls in multiple planes. He continues to display compensatory trunk and upper extremity movements, and occasionally he has to catch himself with the upper extremities. He displays increased confidence and decreased fear of falling forward compared to initial sitting activities. The patient now has trace movement in his left lower extremity and improved trunk control. He performs standing in the parallel bars to promote lower extremity weight bearing and engage core musculature. His knees are blocked to maintain extension.
Okay, that was what I was going to cover here. So if you look, right, where this therapist is working, he is putting a posterior push on both of his knees with his knees. That's why he's able to stand like this. This kid can't stand on his own. But he's providing a posterior push on his knees. He's basically locking out his knees to stand him up. We could also just as well put knee immobilizers on him, which would basically lock the knees out. It would just make it a little more difficult to stand up. So that's probably why this therapist is doing the push instead of doing a knee immobilizer.
And moderate assistance is provided to maintain hip extension.
His chewing gum is
The patient relies heavily on the upper extremities to maintain upright posture.
Your shoulders forward just a little bit. Yeah, sit down.
Maximal assistance is required to guide the patient into sitting position.
All right, so let's look at the final video here. The outcomes.
5.5 weeks after the evaluation, the patient has become increasingly independent and efficient with transfers. Note his effective use of the head-hips relationship. This is now his preferred technique to transfer to all surfaces except the car. He independently moves his lower extremities on and off the wheelchair footplate. He now independently performs a squat pivot transfer to and from an elevated mat.
Right, exactly. We've got some progress, right?
The patient uses a sliding board to transfer independently to and from a car.
There's
He
the semi
prefers
car.
the safety of the sliding board to help clear the gap between the wheelchair and car seat. Currently, his family assists stowing his wheelchair. In the future, the patient may be able to further increase his independence by learning to break down and store the wheelchair himself. With hand controls, the patient will be able to drive independently.
This is usually the hardest part here. Getting into a car is usually okay for patients. Getting out is usually the hard part. And you got to clear the head. Especially somebody that's 6'1". Real quick here. Just the thought process you're doing this. What is the only thing you do not want him grabbing a hold of for support? The door. Good. Excellent, guys. That's moving to the next level. Good job. Why do you not want him to grab hold of that door? It moves. It's not stable. Good. Where else does he not want to put his hands? Under the board. Good. There we go. Good. See, you guys think you don't know anything. Huh.
Standing balance and trunk control have improved dramatically. A Velcro strap is used to maintain the knees in extension. Minor adjustments are required at his feet to optimize positioning. He is able to decrease upper extremity support from the bars and attempt unsupported standing. Assistance continues to be required at the hips, and compensatory upper extremity movements are noted.
Relax your shoulders.
Nope.
Okay.
Observe the patient's improved efficiency to transition from sitting to standing.
We're almost done with this video, so then we'll go back to talking about it.
The Velcro strap supporting the knees allows the patient to remain standing without assistance from the therapist.
All right, so let me stop sharing. All right, so we saw some progression, right? Renee asked, do we have to wear the brace forever? More than likely. Especially with that level. I mean, could he possibly get out of wearing the brace? Maybe. But let's say the patient asked us that question. What would our answer be? What would be a safe answer you could say? Well, I have to. Yeah, if you work hard, we'll see about it. But whose ultimate decision is it about wearing that brace all the time? The doctor. There we go, Kelly. Right? At this point, the doc hasn't cleared you not to be in it, right? So let's keep working hard. Who knows what will happen down the road, but right now we've got to keep wearing it.
So the purpose of the brace is so he doesn't hurt himself?
Two things. Number one, it's because of those the posterior fractures of the spinous processes, so that he doesn't sublux further, right? That's one of them. Now, he was at that point 5 weeks into rehab, so that's not as much at that point. The main purpose of the brace is so that he can use his upper core that's fully functional to substitute for the lower core that he doesn't have.
Oh.
Basically, it connects, think about it. If I can keep this here, I can use that as my core strength because now this is all locked in with the brace. Does that make sense?
Yeah. My question is though, with braces, isn't like the longer you wear it,
You're thinking right.
Yeah, so
the longer you wear it, the more likely you are to become dependent on it, right?
Yeah.
Because your muscles are going to atrophy. But if we know that already stuff below T12 is already just going to waste away anyway, we're not really concerned about that. So how do we prevent the other muscles from atrophying underneath? Like maybe your upper rectus, some of your internal and external obliques. Well, we're going to give him exercise to work on those so that he can still strengthen them. Does that make sense?
Yeah.
Yep. Good question. Great question. Transferring the car. That was pretty impressive. I don't know personally myself if I'd want him not using a sliding board. For that, how he was doing kind of that sling and swing transfer he was doing. I think I'd probably still keep him using the sliding board, even going to the mat. Just because it's a little safer for him. It's not like it takes a lot. All right, it's not like it takes a lot of space anyway, most times, right? If he's going to have it for getting in and out of the car, then he's probably going to have it any other time as well. So just, that's one of those that you're just like, I don't understand why you wouldn't. I saw one neat the other day that the sliding board actually becomes kind of a desk arm. So they can use it to write on and stuff like that. And then they can take it off and it becomes a sliding board. So that was kind of cool. I saw that was something I had never seen before. So you saw overall, you could see clear progression with that patient, right? Definitely was getting better as time went on. Now standing, let me ask you, was that functional standing? Meaning, is he going to progress to functional gait and functional standing by himself? No, right? That was purely for weight bearing. That's all that was for, right? Because we don't want his bones and his legs to start kind of breaking down. So that was why they're standing him up. It wasn't because they're thinking he's going to walk again. We have to be careful because they were given a lot of kind of really encouraging type wording, like patient is able to independently achieve standing. He's not independent. That strap's doing most of the work for him. Right? So we kind of have to be careful with that because we don't want to give him false hope. Maybe we could get him an RGO, reciprocal gait orthosis, where he could stand up on his own. I'm probably going to think about getting him a standing frame for at home, where he can actually stand up for longer periods of time and his parents can help him get standing so he can get weight bearing down through those legs. And he had pretty good attitude. I mean, overall, I'm sure that wasn't his bad days, right? But did you guys understand what they're talking about with the head and hip strategy with transfers? So he's using his head to throw his hip. Does that make sense? So he put an arm over here and used his head to throw his hip, right? It was momentum, exactly, right? So that was kind of all it was using that. And the other thing it was helping him do was kind of, because he could use his head over here, get that sliding board under him, and then do that head and hip strategy. Fama, exactly. So he's using mechanical advantage there, right? And again, positive note, he's skinny, right? I didn't see the video before. I saw the 127 pounds, or now I seem like an idiot. Because I purposely did not watch the video beforehand. I wanted to kind of see it fresh with you guys. But, you know, positive note, he's kind of skinny. So he had a lot of stuff going for him, right? Wheelchair wise, what kind of stuff on his wheelchair does he definitely, I mean, he had a pretty good wheelchair, first of all. I'm just going to say that he had a colors wheelchair. What kind of stuff are you looking at on the wheelchair there that you saw was important? Yeah, what type of armrests? Removals. Yeah, and removable leg rest, exactly. To get them out of the way for his transfer, right? Now, if he's doing Hoyer lift transfers, are we so concerned about the armrests? Nope. Right. I probably would give him fixed armrest at that point because that gives him more stability laterally. Right. I mean, overall, he was good. So in manual, I didn't talk about his manual propulsion of a wheelchair, but I'm assuming with the way he was, he probably could move around the wheelchair pretty good. Right. So you're going to work with him going forward, back, side to side, quick turns, slow turns, over thresholds, in and out of doors, right? What way is the easiest way for a wheelchair patient to go in and out of a door? Like one of the doors going in and out of buildings, like to our suite. Backwards is usually a little easier for them, yeah. Because they can kind of push back with the elbow and kind of wheel backwards, then spin out. Sometimes you can go forwards, but it's a lot of work to lean forward and try to push yourself through that door, right? Unless they've got one of those buttons that it swings the door open, which most businesses should have anyway. But yeah, he had some positive progression there, right? Did that help to see a real spinal cord injury patient? Right, to see kind of what we got another one. I've got another one coming up that's at the higher level. So much better than exactly. That's when I saw these videos, I'm like, they're fantastic. Let's take a 10-minute break real quick because I know I've ran a little bit long here. So let's take a 10-minute break. I'm going to pause the recording. All right, so we're going to start recording again and start getting back into this. And we'll look at another spinal cord injury patient here real quick. So let's take a brief, quick look at the actual case study. I'm not going to go into it as far depth as we went into the last one. So share screen, case study. All right, let's get my chat up. All right, so our next one is a C5, C6 incomplete patient. So we got a 61-year-old, moderately obese, married, Caucasian, English-speaking male who was driving a motorcycle by himself on a midsummer afternoon, was wearing a helmet, and got in an accident. So per his report, he turned his motorcycle too sharply while traveling approximately 45 miles an hour. The bike slid and ended up on top of him. Interesting thing for the, I don't know how many of you guys in here actually either ride motorcycles or have ridden motorcycles. Does anyone in here actually ride motorcycles? All right, so Kelly says, yeah. Is that ride or ride on, Kelly? Just curious. Oh, right, dirt bikes, okay. Yeah. I should have thought of that. Didn't think about that. It's kind of silly of me on the part, right? What this guy did, if you're reading through it, is called a low side. Because there's a high side and there's a low side on a motorcycle. The worst thing that can ever happen to you is high siding a bike. Because the high side throws you off the bike. The low side, you lay down and the bike just kind of lays on top and you just slide for a bunch. So most of the bad bike accidents I see are high sides. So that's when somebody starts sliding and they cut and they try to overcorrect and they get flung off the bike. So let's take a look here. Ended up in a ditch containing water. Was found in a medical emergency personnel with both legs pinned under the motorcycle as partially submerged. Upon arrival to the ED, he was found to have a C5, C6 facet dislocation and lateral process fractures. Rib fractures on 3 through 5, right pneumothorax, requiring chest tube placement and right vertebral artery dissection. And he underwent C5, C6 anterior discectomy and fusion on that evening for lateral fractures. He was immobilized in a cervical orthosis. So he's got a Miami collar on, so he's got a very firm collar. What in that history of present illness concerns you guys? Is there anything that concerns any of you guys? Is there anything on that that you don't understand? Okay, we'll keep moving then. All right, so he's a C7 spinal cord injury. So that means we know that C7 is the level that is fully functional, right? Based on the ASHA assessment, and it's classified as incomplete. So that means he's got some motor function preserved below the neurological level and has sacral segments usually. So one of the medical history here, he has diabetes, right? Controlled with metformin and glucotrol. What type of diabetes does he have if it's controlled with metformin? Type 2, good. Yep, he's got a type 2, right? Because type 1 is controlled with what? Most of the times. Insulin, good. Yep, insulin. All right. So he's also got hypertension controlled with lisinopril and aspirin. So he's got a little bit of high blood pressure, obviously. And honestly, if he's on lisinopril and aspirin, his high blood pressure is probably up there, but it's not too high. Surgical history, removal of squamous cell carcinoma before. He had a hammer toe repair, tonsillectomy, adenoidectomy, and a kidney stone removal. So he's had a little bit of stuff, but really, other than the squamous cell carcinoma, but even that, I'm not so concerned about the squamous cell carcinoma. Hammer toe repair, well, I'm not really worried about that at all right now because they're C7. Patient enjoy. Oh, this is the fun look. Look at this. Patient enjoys his work, his family, riding his motorcycle. He reports rare alcohol and denies tobacco or illicit drug use. Patient works as a full-time as a building technician for a technology company. All right. If a patient reports rare alcohol use, we should always assume it's more than rare. I'm just saying. If they say, well, I hardly ever drink, right? If you don't drink, you're going to say, I don't drink. Yeah. Right? I drink in moderation. Moderation is the place I go to drink. He lives in a ranch-style home that includes a basement. There are 5 steps to enter without handrails. There's a full bath on the main floor with a broken shower, and a full bath in the basement that is fully functional. He lives with his wife, his son, and the son's significant other. PLF, he was fully independent without assistive devices prior to the accident. He stayed active by walking 2 miles back and forth to work each day. Okay. Okay, Mr. C7. Right? Gross range of motion, bilateral extremities within normal limits, bilateral extremities within normal limits throughout, except for straight leg raise. So he's got some hamstring tightness and a rotation bilaterally. Gross motor strength. Most of his, so we got bilateral shoulders, Bilateral elbow extension, 4 out of 5. Wrist extension, 4 out of 5. Finger flexion, 0 out of 5. And 0 out of 5 bilateral lower extremities. Oh boy, we got some issues, right? Looking at this, if he has elbow extension, does he also have elbow flexion? Yeah, probably, right? If he's C7, he's got C5, C6, so probably okay there. Reflexes, normal on a right upper extremity and lower extremity. Trace reflexes on left brachioradialis. Now we're starting to get down into those other areas. Absent on the triceps and biceps reflex on left upper extremity. Ooh, that's going to concern me. Which I don't understand how he could have, but I'm not going to question their ruling here. But anyway, not going to. Light touch intact bilaterally, upper extremity and lower extremity. Pinprick impaired below C7 on right and below T3 on left. That's why he's an incomplete. Rectal tone is present, but no voluntary anal contraction. So he's got, there's definitely something going on back there, but he can't force poop out, basically, is what that's saying. Doesn't say anything about the bladder. So what's that probably tell you about the bladder? Bladder's probably what? If there's not anything specific about the bladder, it's probably okay. Yeah. So looking at him here, every time I see the Asia assessment, I see like just the huge nipples they give this guy. It's just hilarious to me. I don't know why. It just makes me laugh. This kind of tells us everything we need to know, blah, blah, blah. I'm not going to read through all that because that's going to be fun. He's got abrasions on both arms due to road rash. What does that tell you if he's got abrasions on his arms? Kelly, what's that tell you probably if you've ridden dirt bikes before? What was he not wearing? Yeah, road rash. Toad rash could be too. He was in a ditch with water. He could have toad rash. He wasn't wearing a jacket. Yeah. Right? So I have a concern from me standpoint, from a wound care standpoint at this point, because I know he was laying in, it doesn't say, but I'm assuming stagnant water with road rash. So what am I worried about? Yes, infection, right? I'm worried about infection. I mean, I theoretically could even be worried about a fungal infection later on. Right? Who knows if we actually got him completely clean and some fungus didn't grow among us. Right? So, I mean, I've seen it where, you know, somebody had something like this happens. There was one guy that had a boating accident and they didn't get him completely clean after the boating accident. Some fungus evidently got stuck in around his groin area and he got a nasty fungal infection of the testes. So it's the last thing you want this patient to get at this point. So blah, 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 look at all that. Let's look at the video. Stop share. Let's go over to the video for this guy. So I don't need this one anymore. I don't need this one anymore. I don't need this one. All right. This guy is definitely not the same build as the other guy. That is 100% for sure. All right. Think we got a different patient here just looking at this already? All right, I'm going to say it again. What are they missing again? Well, they've got it. It's laying on the mat. It's not on the patient. They brought a gait belt. All right. If nothing else, you guys will get that from me.
The patient is a 61-year-old male who sustained a C5-C6 spinal cord injury in a motorcycle accident. Here, the therapist assists with placement of the transfer board.
Lean to your other side.
The patient is cued to lean to the left.
Okay. And I want you to try and push off of the armrest and off the board.
The patient is also guarded from behind to ensure safety. Application of the head-hips relationship is initiated from the very beginning. The therapist in front maintains a flat back during the transfer.
Good. Go ahead and move your hands.
My spine hurts.
2, 3. Good.
Sitting
All right, I wanna
balance is
pause
an
real
essential
quick.
skill to progress with function.
If I was instructing this person that did this transfer, I'm going to tell them one thing, because that thing I'm going to tell them is they need to listen to Little John. Because you know what Little John would tell them? I mean, yeah, right. He'd tell them to get low. Right? Her butt up in the air like that. I know she flattened her back out. But man, that was just, no. I mean, she got in on him pretty good. I'll give her that. Like, she was in on him pretty well. I would have just gotten that stool completely out of my way and gotten in on him. He is pretty tall. You're right. But she has an extra set of hands there to manage his shoulders. Right? And I know she was trying to get him to do some of it, but he's got nothing in his legs, pretty much in his core. Right? Who did most of that work? Yeah, like if I go back here, let me rewind to the beginning of this transfer here. Just watching this, tell me what you would rate this transfer as far as assist levels.
Off of the armrest. And off
Watch
the
her
leg.
arms.
The
watch her
patient is
body.
also guarded from behind to ensure safety. Application of the head-hips relationship is initiated from the very beginning. The therapist in front maintains a flat back during the transfer.
Good. Go ahead and move your hands. 1, 2, 3. Good.
Sitting balance is an essential.
Okay, good. So Kelly's saying max. I'm probably saying, yeah, I mean, at minimum, he's a mod. At the bare minimum. He would be a max or a mod A of what? How many people are there? 2, right? So what you would put for him is you would put patient. So what kind of transfer did we do? We did a slide board transfer, right? To patient's right side, because that's the direction we went, right? Because we want to put it into relation to them. So to patient's right side, max assist of 2, and then you want to indicate what the second person helped with. Even if that second person helped with the full transfer, you're going to indicate that. But what would you say she helped with in the back? What would you say about her in the back? What was she helping with? Yeah, pivot control, right? And upright posture, cervical stability. Yep, right. She was helping with kind of just keeping him up and upper extremity movement. The other girl was most of the transfer, right? She's probably the lead therapist. So let's take a look at what his strength is like sitting up here.
Skill to progress with functional mobility.
Whoop.
The patient loses balance posteriorly while attempting to sit upright.
Okay, we are doing balance here and we have no gait belt. I swear, I'm going to write F.A. Davis. Right? And not only that, but could that gait belt have helped her transfer better? Yeah. Right? I would say it would have, right? So, anyway.
To ensure safety, one therapist guards in front and one guards from behind.
Okay, so that's a Miami collar, by the way.
The patient attempts to remove one upper extremity support from the knees but loses balance anteriorly. To assist with rolling, the therapist crosses the patient's legs and encourages arm swing to create momentum to assist with transition to the left side. The therapist provides cues for right shoulder protraction to assist in completion of roll.
Okay. Great.
The therapists provide trunk support to assist the...
Hold on 1 second. I want you to look at his legs. what are these things on his legs? They look like foamy things. No, yeah, that's a good guess. Yeah, those are ALPS units. Compression things. I like it, right? Those are ALPS unit, alternating low pressure system, I think is what the abbreviation stands for. Of course, there are names for everything. I've always seen them as ALPS. But what those things are is there's a little hose somewhere in them. And when he gets back in bed, you plug that hose up to a little compression thing at the bottom of the bed, and it inflates and deflates them. And what's that trying to prevent? DVTs. Good. Blood clots, right? It's to prevent blood clots, man. No, it's been to Jamaica.
Great.
The therapists provide trunk support to assist the transition from supine position to long sitting position. The therapists coordinate assistance by moving on the count of 3.
Kind of boost him back so his feet are on him.
The patient attempts to assist with lower extremity management.
Oh, he
fatigues quickly and requires assistance from the therapist to complete movement of lower extremities from the mat. The therapists provide the majority of assistance while scooting to the edge of the mat to facilitate weight shifting. The patient is encouraged to assist as much as possible.
All right, so how much work did that therapist do? A lot, yeah. That therapist was doing a lot. So let me see. If I go straight to the next video here, does it bring you right to the next video with me? Are you guys in the next video? Okay, cool. So I don't have to re-share screen. Awesome. I wasn't sure if it would do that or not. All right, so let's look at the next. Now we're looking at some interventions here with this guy.
Do you want to cough?
He's 3 weeks out now.
Owing to impaired ability to cough independently, the therapist places the hands inferior to the rib cage to facilitate coughing.
Okay, so what she's doing is called assistive coughing. Right, Erica's like, that doesn't look very good. Right, so what stage, yeah, right, what stage, what part of the active cycle of breathing is he working on? What phase? Phase 3, right, forced expiratory, good. And she's trying to help him by basically doing a Heimlich maneuver on his stomach, is essentially what she's really doing. So we'll rewind just briefly here so you can see.
Owing to impaired ability to cough independently, the therapist places the hands inferior to the rib cage to facilitate coughing. An inward and upward push is then sequenced with the patient's breathing and attempts to cough. The patient places his hands posterior to the hips, forming a tripod to assist with balance. Weight bearing on the elbow with return to upright assists with strengthening triceps and core musculature. It is also an important component skill to improve bed mobility and transfers.
Let's try it one more time. Yeah. Yep.
Ball tossing in ring sitting is used to improve sitting balance. Guarding is provided both anteriorly and posteriorly.
Hold on. I want to rewind real quick.
With new
I just want to talk to you guys real quick. All right, so guys and gals, this thing on her hip is called a pager. It's what we used to have before we had cell phones. That little thing used to beep and annoy us in the hospital like crazy. And it would say, like, come to room 203, stat. And the person who was in charge for the day had that pager and hated having that pager. I just thought it was funny that I saw she had a pager. So this is a pretty old video.
With new emerging strength noted in the right lower extremity, strength training is initiated in side lying using a powder board in a gravity minimized position.
Push back and bring it up.
A skate is applied to the patient's leg to increase the range of movement and facilitate strength gains. The patient practices leaning forward in the wheelchair and reaching toward the feet. A seatbelt is worn for safety and to...
He got his ears lowered. Lost a little bit of hair there, didn't he?
Help minimize fear of falling. This activity encourages anterior weight shift needed for transfers. It can also be used for pressure relief if the tilt feature ever malfunctions on his powered chair.
How about your other hair?
All right, let's look at the last video with this guy.
After 8 weeks of inpatient rehabilitation, the patient is now proficient at wheelchair skills outdoors. He changes the drive of the powered chair to increase speed going uphill. The patient is able to execute a full 360-degree turn within a tight turning radius.
Turn the other direction.
He is also able to independently drive the powered wheelchair into a building in preparation for independent community access. The patient has made progress with wheelchair to mat transfers. He continues to use a transfer board. Application of the head-hips relationship remains an emphasis as the therapist encourages leaning forward and away from the direction of movement. Rolling skills have also improved. The patient is able to roll independently with the lower extremities crossed. Momentum is created by swinging the upper extremities. Assistance continues to be required for movement of lower extremities on and off the mat. Practice with this activity will continue in outpatient therapy. Progress has also been noted in dynamic sitting balance. The patient has also made progress in scooting forward on the mat. He leans anteriorly to unweight the buttocks and increase efficiency of movement. The patient is able to lean to the right for transfer board placement and requires minimal assistance for return to short sitting position. He uses both upper extremities to assist with transfer back into the chair. The patient is verbally cued to scoot to the left and backward to position himself in the chair.
All right. University of Michigan Hospital. Well, I'll forgive them for that. Where's all my Penn State people? All right. So, different patient. Right? Totally different patient. So let's talk some concerns there. I mean, obviously I still have concerns because they're not using gait belts. They're just not, and it's really kind of frustrating me. I'm just going to be honest. It's really frustrating. But again, here's my deal with the gait belt. I'm going to tell you, if you don't use the gait belt and you choose not to use it, Dr. Reston's going to come after you. But beside that, if you have an accident, you have a fall with the patient, one of the very first things the fall committee is going to ask you is, was the patient wearing a gait belt? And if your comment is, well, it was laying on the mat beside him, that's not wearing a gait belt. That's displaying a gait belt. I don't even know what you would call that. That is not wearing the gait belt, right? So that's just a safety thing. And again, these videos look pretty old, so maybe they're before we were so concerned about gait belts. Like maybe these were in the 1960s. I don't think so, but so there is that concern I have with this patient. So we already had a kind of morbidly obese patient, right? We know that he's got some issues with blood sugar. I have a concern that they went straight to a power wheelchair. Why do you think I have a concern with him going straight to a power wheelchair? Yeah, Eric was surprised too. Good. He had triceps. Right, sedentary. Good, Justin, right? So what do we know is going to happen to his actual weight? Yeah, making the unhealthy unhealthier. Exactly, right? He's already probably got a poor diet. He already has some excess body mass to him as it is, right? Now, he's going to lose some lower extremity weight because they're going to waste away slowly. But he's going to increase probably abdominal and posterior buttock weight, which is going to put him at more risk for pressure injuries, you know, if he increases abdominal too much, then he can get those nice folds of fat that he can get all kinds of maceration and eventually pressure injuries there as well. Right? You get a big pannus, and that pannus could cause problems. It also makes it difficult for somebody like him that's that size to get dressed. Right? I mean, I know from experience from my family, I'm not the smallest person in the world, but I'm the smallest member of my family. You know, my dad was 425 pounds. When he went in with cancer, watching him try to get dressed when his energy was just non-existent from the chemo was just, it's hard to watch because he just didn't have the power anymore to control that weight. And this guy doesn't. He doesn't have core strength. Right? So he's relying all on his upper body for strength. And I mean, good on him. He was doing some of this stuff, right? Why do you think he was on oxygen the whole time? What gives you what thought process do you think they have for there? That made complete sense what I just said. Why do you think he was on oxygen? He's not breathing properly, right? He's probably got some asthma or something to that effect, right? And he also got, you heard him when she was doing that clearance, like he had some gunk in his lungs, right? He had some gunk in his trunk. You need to get some of that stuff out. So they're probably thinking better to put him on oxygen and give him some supplemental oxygen to make sure he's getting the proper oxygenation of his body than not. He's probably on 2 liters. And honestly, 2 liters is nothing. But that nasal cannula adds what for you guys? A challenge. Because now you got one more thing you got to manage, right? Could you theoretically take his nasal cannula off to transfer them and then put it back on once he's transferred? I mean, yeah. I mean, if he's under, and this isn't a hard number, but if he's under 3 liters, you probably could do that. But it is time consuming, right? But it's also not teaching him the best processes either. So maybe teaching him with the cannula is better for him because we don't know how long he's going to have to wear that, right? What else did you guys see with this one? Did you guys see anything that made you guys concerned or anything like that? Do I still have you guys? Can you hear me? Still here? Okay, good. So no, Renee says no. Was he going to be, let's say, I'm going to use you as an example here, Renee. So Renee goes to see this patient and she's a new grad. She's licensed. She goes to see this patient. Would Renee do well to get some help maybe for at least the first time treating him? Yeah, right. He probably outweighs her by at least 150 or more pounds. Right? Save your back, get a help a little bit. Right? Even me, I've learned from my mistakes. I try to get a little bit of help nowadays when I do stuff, right? Because it's just, you never know, if something can go wrong, it will go wrong. Better to have some help and, eat a little bit of humble pie than not. Is this guy going to end up being as independent as the last guy? No, not at all. Right? It's just not going to happen. Right? This guy may not drive ever again. Right? And so there's going to be a lot of life changes for this guy. So it is what it is, right? We've heard that before. I don't know where we've heard that before. All right. So let me close him down real quick. And we're going to look at one stroke here real quick. All right. Give me a second just to get the videos up. No, I'm not logged in anymore. Great. Thanks. There we go. Now I'm logged back in. Okay, video case studies. What's the first one I have? I have a left CVA. Let's do the left CVA. That's an ischemic, so we'll look at that. That's good. All right, give me 1 second here, guys, just to get the videos up. All right, so we got a left CVA here. So CVA means we have a what type of patient? CVA is a what? Stroke, good, right? So let's take a quick look at the case history here real quick. All right, there we go. So we got a stroke up. We've got a left ischemic CVA. So what type of stroke does ischemic mean? Ischemic is not necessarily small. Ischemic is a blockage or a blood clot, again, a blockage somewhere in the brain, versus hemorrhagic, which is a burst, right? So we've got a blocked pipe, not a burst pipe in the brain. All right, so we've got a patient who is a 67-year-old female who has had a left ischemic cerebral vascular accident with resultant right hemiparesis while traveling in Cuba. Okay, so we know we have a left side stroke. What side's probably affected? Right, good, correct. Right is correct. So records from the in-care acute care in Cuba are extremely limited, and there are no diagnostic scans, CT or magnetic resonance imaging data to identify the specific site of the lesion. That doesn't help us, right? Because that means we don't have really any good data to go off of. Patient was admitted to an inpatient rehab facility in the United States 10 days after the stroke. The case follows the patient during the inpatient rehabilitation hospital episode where goals are focused on promoting function. So this patient has uncontrolled hypertension, dyslipidemia, and DM type 2. So blood pressure is out of whack. What's dyslipidemia? What's dyslipidemia? High cholesterol, probably. And when you classify it as dyslipidemia, that means it's out of whack. So we have 3 things here. We have uncontrolled hypertension, whacked out cholesterol levels, and DM2. At this point, I'm not saying, I don't know how she had a stroke. I'm going, why hasn't she had a stroke before now? And then I'm going to the next thing and I'm going, ooh, there's another predisposition for a stroke. She's had a hysterectomy, right? So medication, she's on Actos, metformin, metoprolol, lisinopril, Prevacin, and aspirin. So she's on a lot of heart meds, right? That's basically what that says. She's on a lot of heart meds and she's on a lot of blood pressure meds and a lot of DM2 meds. So she's got no history of smoking or illicit drug use. The patient is a social drinker, very social. Her husband is deceased and she has 2 grown children. Her son lives in Cuba and her daughter lives in the United States, but not locally. All right. Concerns with social history? Any concerns there for you guys? Just any red flags? Yeah, not enough people around. Yep, right. We don't have help. Living environment. The patient lives with a cousin in a first floor apartment with no steps to enter. Okay, well, that's a little better, but still. She was independent with basic and instrumental activities of daily living and ambulated without an assistive device. Okay. So let's look at some review of systems here. CV system. 146/76. Heart rate's about 76, respiratory rate 16. She's able to tolerate a 60-minute treatment with occasional rest. So I'm worried about the blood pressure there. All right. Muscular scale. No asymmetries noted in the lower extremity. Shoulder asymmetry, left shoulder elevated in both sitting and standing. So left side's up like this while the right side's kind of doing this. Left upper extremity and lower extremity, active range of motions within normal. They have active range of motion impairments of the right upper and lower extremity. So we know that she's going to be right affected. Makes sense. Left upper and lower extremity strength, good. Strength impairments of the right upper extremity and right lower extremity. Great. That tells us not a whole lot of anything. We just know she's weak. Height, 4'9". I am cheering up and down right now. Weight, 134. BMI is about 29. You know, the weight 134, that's probably out of whack for 4'9". But somebody that's 4'9" is a little easier to manage, right? I'm just saying. So I'm cheering. I'm going, yes, I drew the lucky straw. Maybe. Get there and she's completely destroyed and I can't do anything with her. But all right, she's got diminished neuromuscular control and she got right hemi body problems, right? Impaired coordination of right upper extremity, lower extremity. She got slight hypotonia in synergistic movements. So probably when she's doing stuff, she's getting weird synergies going. Maybe she's got ATNR, maybe she's got STNR, we don't know. Integumentary, she got visibly skin intact, normal skin color and temperature, no presence of edema noted. Good, so not concerned there. Patient's primary language is Spanish. I'm in trouble. So how many of you go see that and go, primary language is in Spanish and you don't start freaking out? Does anyone in here not start freaking out? I will. I'll openly admit it. I don't speak Spanish. Other than, you know, where's the bathroom? Can you serve me 2 beers? And dolor. That's about my limit of Spanish. You would think I've learned more by now, but I'm just not that good at it. Speak like 4 other languages, but can't speak Spanish to save my life. She has good attention span for 45 to 60-minute treatments. That's a little concern for me because if she has good attention span now, that means she probably didn't at one point. So she has no aphasia, no dysarthria, no dysphagia noted. So speech, swallowing, talking, we're okay. Sinus bradycardia is noted, 57 beats per minute with T-wave abnormality. Okay, so we've got some signs of some heart issues. Is it a big surprise that she has heart issues? Not really. No, nothing surprised me about this patient yet. So we talked about range of motion. We talked about that. Let's see if there's anything else here that I'm really, no, there's not much else. Now she does have a FIM here, right? So they did a FIM. Let's see, it's present in 10-2A. So that is 10-1. So we did a FIM here, right? And remember, a FIM has all these different things, and that rates her ability to go home or go to wherever she's going, right? So in order to be able to score somebody in the FIM, what do you have to be? Do you remember what I said? You have to be certified. So you have to have taken a FIM test in order to actually score somebody on the FIM. Some of you may actually take your FIM test while you're out in the clinics. Some of your hospitals may require you to quick study up and do it. Great, take it. I don't know if any of you are going to a hospital, I'm not sure, but we got a FIM. That's kind of what the FIM looks like. Doesn't really tell you all that much, but it's good for social work or for case management to help us to see where she's going. Let me stop share here and we'll go to the video. Cut to the video, Bob. Nope, that's not the videos. That's the other window. There's the videos. All right. Share screen. Video. Open chat. There we go. All right, here we got a video. Yeah, Jamie, pull that up for us. You ever do DMT?
The patient is a 67-year-old female who sustained a left ischemic cerebral vascular accident with resultant right hemiparesis while traveling in Cuba. Records from acute care in Cuba are extremely limited, and there are no CT or MRI results specific to the site of the lesion. The patient is admitted to an inpatient rehabilitation facility in the United States 10 days post-stroke. The patient transitions from sitting to supine. She experiences difficulty moving from side lying to supine. Note the decreased use of the right upper extremity and the synergistic position of the right lower extremity. She requires minimal assistance to transfer from supine to sit. Note her reluctance to use the right hemibody during the activity. While the patient attempts to stand, note that the right upper extremity is not used at all during this task, and there is avoidance of weight shifting toward the affected side. The patient sits unsupported while reaching with the affected upper extremity. She requires manual cues to shift her weight forward while reaching and presents with poor motor control in the affected arm both proximally and distally. Compensatory strategies at the shoulder and the synergistic pattern of movement are apparent.
One thing here, this is just to bring this up for me as a previous manager. Her polo that she's wearing, what do you think my problem is as a manager? Yeah, it's too unbuttoned. Yeah, I'm going to be honest. At least that bottom button needs to be buttoned. Because she leans forward and what happens? Yeah, free sight right down the front of her shirt. And there's going to be some patient that makes comments. So just as a thing, and also I hate to say it, but if my clinic's polos are this low cut, I may ask my employees to wear an undershirt. Or what is it you girls call a cami or something like that? Just something to wear underneath it. To just to make modest a little bit better for you guys. I'm just being honest. That kind of bugs me a little bit as a former manager.
She transfers from the wheelchair to the mat with minimal assist for balance and safety. Note the non-use of the affected upper extremity. When transferring toward the affected side, non-use of the affected arm is even more pronounced, and there is poor eccentric control when sitting. During ambulation, note decreased ankle dorsiflexion in swing, Trendelenburg pattern on the right, poor knee control in stance, and marked trunk asymmetry.
All right, do you guys see the Trendelenburg? Let's rewind it real quick here.
More pronounced, and they're sitting. Note decreased ankle dorsiflexion in swing, Trendelenburg pattern on the right, poor knee control in stance, and marked trunk asymmetry.
Boom.
Observe the significant lack of hip and knee control. Trunk asymmetry is also clearly evident. The lateral view of ambulation clearly shows the patient's difficulty with knee control in stance. Note the marked hyperextension of the right knee.
Ow.
To ascend stairs, the patient circumducts the right lower extremity, hyperextends the right knee, and requires cues to use the right arm on the railing.
Husband's having a birthday over there.
As the patient descends the stairs, note that the right knee is not used eccentrically, and she barely puts weight through the right arm.
All right, fall risk. Good, yes. Tyler says weak left glute med. Yep, we've got a weak left glute med. Does that have anything to really do with the stroke, do you think? Because she's got a right Trendelenburg, so we got a weak left glute med. Do you think that really has anything to do with the stroke? No. She probably just had a weak left glute med, but now she can't compensate, and she has nothing on that right side to compensate with. Right? So now it's just showing. If we watched her before, if you'd probably watched her before therapy or before the stroke, she probably had a similar gait pattern. It's just it wasn't as pronounced. All right, let's look here, some interventions. This looks like safety. All right, so this is one of those light gait systems, right? What this is the body weight harness that takes some of her body weight off her so she can walk.
This treatment session takes place 4 weeks after initial examination. The patient is instructed to push into the therapist's hands and follow her hands with her eyes and head to promote weight shifting to the affected side. The activity promotes both concentric and eccentric knee control. During bed mobility training, the patient performs lateral scooting. The therapist provides assistance and cueing to promote symmetrical weight bearing.
Kinesio Tape for swelling.
Rolling activities incorporating PNF patterns are progressed to include resistance to upper and lower extremities. Using a ball, the patient performs a high kneeling activity. She has difficulty shifting weight forward. The therapist cues verbally and manually to promote co-contraction on the affected limb. The patient is cued to move the ball forward and backward or side to side. Verbal and manual cues are provided to facilitate use of the right knee. Here, the patient is working on scapulohumeral rhythm without substitution. The activity is performed in standing, so weight shifting is also occurring in the lower body. While weight bearing on the involved extremity, weight shifts and stepping are practiced.
So what is that exercise there she's doing called? So she's standing on a higher platform and coming down and tapping her heels. It's got a real fancy name. Heel tap. There you go. Right? That would be, I would probably call that an elevated heel tap because she's coming from an elevated position. Just indicate what leg you're doing it on. Right? What type of control is she working there? Is she working concentric or eccentric? Yes, eccentric step downs could be, yep. The only reason I don't say she's doing a step down is because she's not coming the full way down. Right? She's only coming down, tapping that heel and coming back up. Or at least that's what I'm assuming she's doing. I stopped it for
Emphasis is on both concentric and eccentric right knee control.
She's not even getting down to the heel. She's scared. Come on, tap that heel.
Verbal and manual cues are provided as the patient steps onto a short step with the affected extremity. The cues discourage circumduction of the hip.
Okay, real quick. Going up the stairs. Do you guys remember what the little phrase to remember for having an affected side is for going up and going downstairs? Up with the good, down with the bad. Good. All right, so we remember that much. I'm good. I'm glad. Right? The other way you can remember it is good goes to heaven, bad goes to hell. But either way, it helps you remember it, whatever works.
Hip and promote effective use and timing of knee musculature. Body weight supported treadmill training provides a safe environment to increase gait speed. Kinesio tape is applied to the right knee to encourage appropriate motor control during stance phase of gait. Note that the patient struggles with knee hyperextension and foot slap on the right. An elastic bandage is used on the right calf to increase dorsiflexion during swing and reduce knee hyperextension during stance. Also, the Trendelenburg gait is more evident in this view. Cueing is used during stair training to promote eccentric control of the right knee. Taping is also used to facilitate knee control. The patient is using a step-to-gait pattern.
All right, let's look at the last video here for our Miss Esmeralda. I don't know what her name is. I'm going to call her Esmeralda. She got a smile now.
Outcomes were observed 9 weeks after initial examination. The patient now transfers from sitting to supine independently and incorporates the affected extremities into the activity without cues. The patient is also independent in transferring from supine to sitting using the right upper extremity to assist in the activity.
Much better. Look at that.
The patient transfers with modified independence between the wheelchair and the
Look at her
mat.
smile.
She also incorporates the affected extremities into this activity. As the patient sits unsupported and reaching with the affected upper extremity, note her improved motor control of the affected arm, less use of compensatory strategies, increased speed of movement, and improved grasp. She is able to cross midline and remain stable during the activity.
I love the child lock they have in the back.
The patient now ambulates using a hemicane with supervision. Use of the hemicane and her improved strength allow for a decrease in Trendelenburg gait, improved right knee and ankle control, and improved trunk symmetry. The posterior view demonstrates the patient's significant improvement in hip control with a marked decrease.
All right, I'm going to say something about the hemi walker here. I really think she could have that hemi walker one notch higher. And the only reason I'm saying that is her elbow is locked out most of the time. You guys remember what degree you kind of want at the elbow? Yeah, about somewhere between 20 and 30, right? Good. 25 is ideal. But I don't ever measure in fives. So as long as they get between 20 and 30, I'm happy.
In Trendelenburg pattern.
But look at that elbow. It's almost
Trunk
locked
symmetry
out.
is also notably improved. Although control of the knee has improved, motor control problems are still evident and will be addressed further in outpatient sessions. The lateral view clearly shows the patient's improvement in knee and ankle control.
Much better.
Trunk control, posture, and hip control and stance are also markedly improved. She still has many gait deficits, including lack of right arm swing, a step-to-gait pattern, and slow gait speed. However, she is able to return to the community at this level and continue therapy as an outpatient. The patient is now able to ascend and descend stairs with supervision. She uses both handrails for support and is safe for community discharge. She should eventually be able to perform this task with a reciprocal foot-over-foot pattern and will continue toward this goal in...
Okay, one thing. They said with supervision, I'm going to say at minimum, she's on a contact guard assist. If she's got a hold of that gait belt, she's a min assist. Even if she's outside the stairs like that, that's not supervision. Supervision would be kind of floating around her, but not touching her. So I'll go back. We'll take a look at that. So I got to ask, what gait pattern is she using? Let's go back and look. Let's start from...
Trunk symmetry is also notably improved. Although control of the knee has improved, motor control problems are still evident and will be addressed.
Assisted device, affected leg, good leg. Assisted device, affected leg, good leg. Modified 4, good. That's the mod 4 pattern. Remember that mod 3 is your partial weight bearing pattern. Right? Just that's, I mean, that was a beautiful question, Renee. Thank you. That actually, I didn't even think of asking that, but that was a beautiful question. So that's mod 4. That's the assisted device, opposite leg, good leg. Assisted device, opposite leg, good leg. What if she was moving the assisted device with the opposite leg? Now what is she? Mod 2. Good.
Further in outpatient sessions. Markedly improved. A step-to-gait pattern and slow gait speed.
Yeah, so she would be modified 4-point gait pattern with step 2 or modified 4-point step 2 gait. Because she's stepping just to the walker. She's not going through.
However, she is able to return to the community at this level and continue therapy as an outpatient.
Those bowling shoes.
The patient is now able to ascend and descend stairs with supervision. She uses both handrails for support and is safe for community discharge. She should eventually be able to perform this task with a reciprocal foot-over-foot pattern and will continue toward this goal in outpatient therapy.
All right. Stop share here. All right. So a couple things I noticed with her. You could even see when we're in the early stages, especially, you could even see she had some facial droop going on. I don't know if you guys noticed that, but she definitely had where this side of the cheek was kind of down like this. And she, you know, when she would move the mouth, this side of the mouth would move. This side would just kind of stay dangled down. But she had some neglect at the very beginning, right? She was just constantly kind of letting that arm just dangle and ignoring it. And with the fact that she had that shift where this shoulder was up higher than this one, that opens this one up for subluxation. Because that shoulder can just as easily, right? Supraspinatus can stop pulling up on that that arm, and then that shoulder just goes whoop, and drops slightly out of joint. And then we've got other problems. Not a bad stroke, I don't think, right? She wasn't horrible. I keep using horrible as a term, but it's not a technical medical term, right? If you had her for a stroke, could you handle that? What do you think?
What was the question?
Said if you had her for your stroke patient, would you feel comfortable handling her? Other than language. I mean, for me, language would be my problem, but I could get across enough doing Mr. McKeever pantomimes to get stuff to her, right? What if you don't speak their language? Does that mean you can't treat them? No, I mean, here in Vegas, there's a good chance somebody in your clinic speaks Spanish. It's a pretty good chance. And if you do speak Spanish or you are multilingual, you have a little edge up on people that don't. So if you want to expand your horizons for potential job openings, learn another language. We have translators on our phone. Exactly, Renee. Thank you. But, she speaks Spanish. What's the chance that someone in your clinic speaks Armenian? Pretty low, right? So Spanish, yeah, there's a chance. Even in the East Coast, I'll be honest, there's a chance somebody in the clinic speaks Spanish. But, Armenian, I had it where it was like Mongolian. And I didn't even know there was a separate dialect for Mongolian, right? I learned. I'm like, okay, I did not know that. Right. So, yeah, that's what I kind of thought. I'm like, well, maybe they understand Mandarin. Nope, not at all. So, there are things like that. You're just going to have to get through it, right? Or maybe you got somebody that is deaf, right? You're just deaf. At that point, I know enough sign language from working with kids that I can work with kids that way. But if I sign towards an adult, they're going to be laughing at me the whole time. What are you signing? Did you just give me a bad word? I don't know what you're doing. Right? So just work through it. But yeah, I mean, there's always language translators now. There's one that I'm really kind of excited about that's coming out that works with Cerner, which is one of the healthcare systems, that actually is a pair of headphones that they can put on, and you can wear one earbud, and when they speak, it translates into your ear, and then when you speak, it translates into their ear. Which I can imagine how bad the translation probably is, because it's right. It's probably going to be rough. I'm going to be honest, but even at rough, it's better than nothing at all. Thanks, Jesse. Yeah, right. That's kind of cool. It really opens up the ability to travel too, when you think about it, because now you maybe can go to places you might have been worried about before because you couldn't speak their language. If you ever want to learn a language that makes absolutely no sense, go learn Danish. I learned it. It makes no sense. You think that our dialect has some weird dialect rules? Oh no. Or go learn Cyrillic. Right? So the overall language barrier is a problem. Good news, she didn't have any other speech problems that along with the strokes. That's a bonus, right? She had some rough, she was kind of rough at the beginning, but even at the beginning, she was pretty decent. I'm concerned because she's already got all these meds that she's probably going to have what? Another stroke. Right? She just, to me, that social history and that past medical history tells me I'm opening myself up for another stroke. Just because people just don't change. We don't change habits, right? It's hard to change a habit. Was there anything you saw in that case study that interested you or that came out and kind of caught your eye? Okay, that's right. Thank you. Somebody asked about the point of Kinesio Tape. Okay, so I was really confused with that Kinesio Tape job because the way I looked at a Kinesio Tape, it was a way that I would Kinesio Tape to help with swelling. But they were trying to say it was to help with knee control, and I'm not so sold on that with where the Kinesio Tape was. That also could have been to help with dorsiflexion. So Kinesio Tape, depending upon how you use it, and I'll try to, I'll see if Dr. Reskin can just kind of briefly talk about it next semester when we have current trends in healthcare, because she actually is a certified Kinesio Tape specialist. I'm a dabbles in Kinesio Tape and plays with it specialist. But Kinesio Tape can be used for a bunch of things. It can be used kind of to help support a knee joint, like you can surround the knee joint in order to provide it with some lateral stability, right? You can use it to pull the patella to one side or another to help patellar tracking. You can use it to help lift some of the skin off that underlying fascia, which is what I thought that was for, which can then help some decongestion so she doesn't have as much swelling. But theoretically, they could have been putting it on so that the pull helped pull the foot upwards. So that, if she lifted up her foot, it kind of helped with dorsiflexion, which is maybe what that was for. I'm not quite sure what they used it for. I don't think it was they keep using this term. I don't think it means what you think it means. I don't think that tape job was for the same thing they thought it was for, but it can be used for a bunch of cool stuff. I've used it for proprioception a lot. So with the patient with the subluxed shoulder that's kind of like this, what I'll do is I'll put Kinesio Tape. I'll start the Kinesio Tape on the lower part of the arm and do a superior pull with it. So this is kind of my anchor point. I'm going to pull the tape and stretch it this way so the contour of the tape pulls the arm up. Now, it's not doing physical lifting, maybe a little bit, not a ton. But what it does is it gives proprioception of that pull up so the patient feels that and goes, oh, I've got to lift my shoulder. Right? I had a patient that had real bad protraction of the scapula. So like this. And I did a posterior pull with it. So I started here on the deltoid and I strapped it back and I ran the Kinesio Tape all the way back to the spinous processes. Now, it didn't pull her shoulders back. But when she was sitting forward, she had this slight feel of the shoulders being pulled back because of the Kinesio Tape. And it reminded her, oh yeah, sit upright. And so that's providing a little bit of proprioceptive input. If you've got somebody that maybe has bicipital tenosynovitis, where that tendon's kind of slipping in that bicipital groove, you theoretically could put a tight Kinesio Taping over it, and that could help keep that down a little bit more. Are there tapes that have medicated with numbing? I mean, there's not going to be tapes with it, but there are lidocaine patches and stuff like that. Salon Passia, right? There's even just regular, like in the hospital, they have lidocaine patches as well. So like maybe that patient that had the lower back fracture, right? We could even slap a lidocaine patch on that lower back, and that can help numb out some of that pain when he was saying, when he was leaning forward, he had a lot of pain. But not tapes we're going to deal with. We could do, now we may do something like ultrasound with lidocaine or iontophoresis with lidocaine, but there's not a tape that has it. I'll go over really really basic level kinesio taping and mechanical taping next semester when we talk about prosthetics and orthotics. But when I say really basic, it's really because kinesio taping and mechanical taping is almost, it's not really more of a specialty of athletic trainers, but it's kind of more in their wheelhouse than it's in our wheelhouse. Now, it doesn't mean you guys can't become CTK certified Kinesio taping special CKTS, I think is what the abbreviation is. I don't know. Just add letters behind your name. And I like Kinesio Tape. I've used Kinesio Tape a lot. I use it a lot when my TFCC in my wrist is bugging me. I'll Kinesio Tape across it to help kind of give me some proprioceptive input to think not to sit like this with my wrist all kind of cocked down and use better posture when I'm using a mouse. But there's a lot of things Kinesio Tape can be used for. Like I said, I don't think that was getting used for what they thought it was getting used for there. Do we need a break, or do we want to push through and then just get out early? How are we feeling? Push. I gotta push. Because I want to look at a Parkinson's. Actually, I want to look at the other stroke patient now that I see it. I think the other stroke patient is a little bit more involved here. Let me get this other one. So that was we did right CVA, so we want left CVA. And bring this up quick. Nope, that's the left CVA that we did. We want the right CVA. Good job, Mr. McKeever. It doesn't look that bad, but we'll see. Copy link address. And just to let you guys know, you all have access to these videos from your book. Your book gives you access to the FA Davis Plus website, which the FA Davis Plus website has all these videos and all these case studies and all this stuff that you can use to help review for your tests and also for your boards later on. All right. So we're going to go in blind. Let's not look at his sheet here, and let's go straight into the videos. And then you tell me what you guys see with this patient. So let me share screen again. All right, so we got our stroke patient here. All right, so just looking at him before I even start playing the video, what side of the brain is affected? Flip it. Right side. It's the left side's, his left side's kind of contracted, so it means it's the right side of the brain. He's looking opposite of you. Don't forget about that. Let's listen to Jimbo here. I don't know what his name. I'm gonna call him Jimbo.
The patient is a 49-year-old male with a history of right hemorrhagic cerebrovascular accident 6 years ago, status post-aneurysm clipping. The patient is attempting to transfer from the wheelchair to supine. He uses his right hand and foot to position the left lower extremity prior to transfer. During the transfer, notice the lack of weight bearing through the left lower extremity. Once seated, he sets the chair on his right side because he is unable to safely transfer toward the left. Note that he hooks his right lower extremity under his left to place his feet on the mat.
This dude's pretty functional.
Roll to the right, please.
Here, the patient completes rolling. Note that because of motor control deficits on the upper left and lower extremities, he has learned to compensate by using his right upper and lower extremity to assist.
And onto your back.
When transferring from supine to sit, again the patient employs compensatory strategies to complete the task. As the patient transfers from the mat to the chair, again he exhibits reliance on his right side with lack of weight bearing through his left lower extremity. When performing sit to stand transfers, there is significantly...
Okay, so what's it called? So the amount of just disregard he has for that affected side, what is that called? Because he's almost completely disregarding his left side. That's a true hemiplegic neglect. Right? He is truly hemiplegically neglecting that side. He's just ignoring it, like it's not even there. Right? Or more that it's almost an annoyance to him, right?
Decreased weight bearing through the left lower extremity
He's not even got
throughout
the
the
leg
task.
down.
For wheelchair mobility on a level surface, the patient does not utilize the left upper or lower extremity to complete the task.
Lift your right hand above your head as high as it goes.
The patient performs shoulder flexion first with the right side, then with the left. Note the upper left extremity flexor synergy during the activity, as well as the right lateral trunk side bend and rotation to assist in completing the task. The patient also exhibits clonus.
All right, so there, I want to show that again real quick.
Right hand above your head as high.
So watch the right hand go up, and then watch the
Lower
left hand go
extremity
up.
to complete the task.
Lift your right hand above your head as high as it goes.
The patient performs shoulder flexion first.
All right, even that had some issues because he did one of these, like almost punching up rather than doing a nice smooth shoulder flexion. So I'm thinking he's cheating even a little bit here. So he's got some lack of motion in that right shoulder. It could be from previous work injury. We don't know what it's from. But when they say flexion synergy, what they're saying is watch as he tries to flex that anterior deltoid to move into shoulder flexion, that his elbow flexes up and his wrist flexes too. And then eventually he'll get clonus.
First with the right side, then with the left. Note the upper left extremity flexor synergy during the activity, as well as the right lateral trunk side bend and rotation to assist in completing the task.
Here comes
The patient
clonus.
also exhibits clonus. Here, the patient performs hip flexion first with the right side, then with the left, but only achieves minimal hip flexion against gravity with associated left hip external rotation and knee extension. When performing knee extension first with the right side, then with the left, he attempts to initiate the task on the left with posterior trunk lean. There is minimal knee extension against gravity. The patient presents with sustained clonus of the left gastrocnemius during spasticity testing.
All right, now that you've seen clonus, does it make sense now? Does that help cement it a little bit more in your brain? Good. See, I knew these videos were going to be helpful. All right, let's look at Jebediah here again. Keep changing his name.
This treatment session takes place 6 weeks after the examination. The patient practices high kneeling exercises, which decreases the degrees of freedom for lower extremity control, thus focusing on hip and trunk stabilization and improved symmetrical weight bearing. He requires both tactile and verbal cues to improve posture, symmetrical weight bearing, and to facilitate hip extension. The activity has been progressed from stable upper extremity support and static kneeling to using the ball for upper extremity support and performing a more dynamic activity such as mini squats.
Okay, so he is not doing a mini squat, first of all. How would you document that exercise? Hold on.
Ball for upper extremity support and performing a more dynamic activity such as mini squats.
What would you call that? Because that's not a mini squat. Does anyone have any kind of ideas? That's going from low kneeling to high kneeling. So low kneeling is where you're sitting. Yeah, low to high kneeling. Good, Hector, right? That low kneeling is when you're sitting back kind of on your heels. And then high kneeling is when you're upright. Does that make sense to everybody?
The patient practices sit-to-stand transfers from an elevated surface. He is instructed to place the right hand on his left thigh to maximize proprioceptive cues through the lower left extremity and to minimize use of the upper right extremity to complete the task. This facilitates improved weight-bearing symmetry.
Move your right foot over.
He requires verbal cues to improve anterior weight shift. The patient practices weight shifting to the affected side.
What does she have that's helping him tell where he is in space? A mirror, yeah. That's what that thing is right in front of us right now anyway. It's a mirror, right? It's helping him see how he's doing. But yes, oof, thank you. Like, he's got her by about a good, probably at least 5 to 6 inches in height. She definitely needs a gait belt.
I don't want you to pick your foot up.
The therapist provides cues to shift the hips toward her shoulder. A mirror is used for visual feedback. Owing to impulsivity and decreased attention, the patient occasionally attempts to step with the right lower extremity despite the therapist cueing to maintain static standing. This closed-chained activity assists to strengthen the hip and knee extensors using a functional movement pattern. The therapist points to the left quadriceps to make the patient aware of the muscle contraction. When sitting, the right hand is placed on the left thigh to improve weight-bearing symmetry. To address clonus in the left gastrocnemius, the therapist provides pressure through the knee to slowly stretch the gastrocnemius and temporarily resolve the clonus. The patient performs a forced use activity in standing by stepping onto a 2-inch step with the unaffected lower extremity. This activity forces weight shift onto the left lower extremity while standing. Note the occasional clonus and the increased extensor tone in the left upper extremity.
Two more good ones.
All right, last video with this guy.
Overground ambulation is examined after 8 weeks of therapy. A straight cane is used with a tripod attachment, and the patient is wearing a left articulating ankle-foot orthosis. Note the occasional clonus of left lower extremity that impacts balance. He requires moderate assistance for ambulation to assist with balance, weight shift, and placement of the left lower extremity at initial contact. He requires a wheelchair to follow secondary to decreased balance and occasional impulsivity. Note the therapist's use of her own lower extremities to assist with swing and stance phase, while her upper extremities assist with balance and weight shift. There are a number of gait deviations, including but not limited to decreased gait speed, decreased step length bilaterally, left Trendelenburg during stance, and decreased heel strike at initial contact.
Basically, this whole gait's messed up.
To sit, the patient is asked to remove his hand from the cane to improve symmetry with the stand-to-sit component.
How's New York? Okay. Good. Tyler, I would suggest, that was one of the things I was going to say. I was going to say Hemi Walker probably be better off. The only reason she may be doing a tripod cane is maybe that's what he has at home. And maybe he doesn't qualify to get some new equipment or something like that. I don't know why she was using a tripod cane. I don't think I've ever actually used a tripod cane. But I'm going to be 100% honest. Where do you think I would be working with him on that at? What that? Yeah, I'm taking him to the parallel bars, dude. He was a wreck. because with that parallel bars, then I can get him to engage that affected upper extremity, right? Because the way she was doing it, is he using his other upper extremity at all? No. Right? So it's further enhancing that neglect. Now, maybe if she was trying to work on some community ambulation, like maybe she's getting ready to go out to a sniff or something like that. So she wanted him to be able to go to a dining room or something like that. Okay, I could see that. But I'm going to be honest, I'm going to have that guy in parallel bars, and I'm going to be beating him up and down that parallel bars, walking forwards and backwards, forwards and backwards, forwards and backwards, getting him to because walking backwards, he can get a good heel cord stretch going on, and that can help slow that clonus down. What else could we do to help the clonus? So you heard saying getting a good deep stretch going. Do you remember what I talked, some other things we could do? So you could do some deep pressure. So go down to that gastroc and kind of put both your fingers kind of in either of those heads and put a little bit of deep pressure into that muscle. That can help with clonus sometimes. And then I said one modality kind of helps with it as well. What's going to slow down? No, I mean, it could. Actually, it's actually not a bad idea, Hector, maybe later on. What modality is going to slow down nerve conduction? Ice. Yeah, right? And you could even do something we don't even do anymore, which is spray and stretch. Theoretically, would be really good for him. Even though like we don't ever do that anymore for him, spray and stretch may be a really good idea, where when he's getting that sustained stretch, I'm spraying him with vapocoolant spray to kind of calm down that errant nerve signal, right? But I could use a little bit of ice massager, especially if that clonus just is not settling down. I could use a little bit of ice on that to kind of calm down the nerve signals and say, okay, we're okay, right? That's the nerves just kind of freaking out going, I don't know what's going on here. Is that a lower motor neuron or an upper motor neuron symptom? Good, yes. Did you look or did you remember it? Did you? It's okay. Well, I mean, at least you're honest. Okay, so he had some definite issues, right? Is he going to be able to go home by himself? I didn't look at what his case study was. I really didn't pay too much attention to it. What do you think? Home by himself, right? Absolutely not. I'm just going to look at what his thing says here. So he was a hemorrhagic stroke, just to let you know. So he's 1 in maybe 10 that you're going to see. Because hemorrhagic strokes, most of the time, guess what happens to them? They die. So the fact that he actually, lived through it's pretty impressive. So he lives at home in an accessible apartment and has a home health aide. So he actually, he maybe, I don't think he's going to go home, but yeah, he's a hot mess. Let's see, 11:38. Oh, somebody said no. Let me see here. How long is this Parkinson's one? I may just post it for you guys to watch. Let me see what the Parkinson's one is, because that one was actually really good. Parkinson's. There he is. A little shaky on where it is. No? No one laughed at that? Yeah, this one is. You got it. Okay, good. We can watch. There's only a few minutes, so let me get these up because at least we can see a real Parkinson's patient here. Oh, where'd my web go? There it goes. And back. And get the link.
This treatment
no, mute. I didn't start you yet. I think they do some PNF with this guy, so it's actually kind of good to see. All right. There we go. Let's look at this guy. This is a Parkinson's. Chat. There we go.
The patient is an 83-year-old male diagnosed with Parkinson's disease at age 77. He is unable to scoot to the head of the bed due to a fixed flexed posture, decreased hamstring and gluteal strength, and decreased hip extension range of motion. During transition from supine to sit, rigidity of the lower quarter and deficits in core and upper extremity strength are apparent. Moderate assistance is required to advance the legs off the edge of the bed and guide the torso to a vertical position. Sit to stand transfer is impaired by decreased core and lower extremity strength. Note the dyskinetic movements and poor eccentric control as the patient returns to sitting position. Upon stair descent, imbalance, poor motor planning, and posterior center of mass are apparent. A head-mounted laser is used to grossly assess full body rotation. Once the patient was able to tolerate outpatient therapy, the Equitest and video gait analysis were used to examine complex multiplanar movement.
Man, his posture's bad.
This treatment segment takes place 3 weeks later. Upper extremity flexion patterns are used to promote improved posture, trunk mobility, and costal expansion. Interventions to improve lower lobe aeration and pulmonary hygiene are often important elements of the plan of care for patients with Parkinson's disease. To decrease iliopsoas and rectus femoris tightness, the contract-relax stretching technique is used because it promotes autogenic inhibition.
Oh God, bad body mechanics.
The patient is instructed in a home stretching program to be performed independently.
More bad body mechanics.
Exercises are chosen to improve multiplanar trunk mobility and challenge the patient's balance.
What's he doing there? What patterns?
Boxing is a fun way.
What pattern is he doing there?
Boxing is to improve multiplanar trunk mobility and challenge the patient's
D1 and
balance.
D2, right? Yep, good.
Boxing is a fun way to incorporate multiplanar movements that challenge the patient's motor planning, sequencing, hand-eye coordination, balance, and cardiovascular system. Sidestepping improves the patient's frontal plane stability and balance. Braiding emphasizes lower trunk rotation. Note the patient's decreased functional transverse range of motion and poor balance when the base of support is narrowed. Walking backward with resistance is used to strengthen hip and spinal extensors. Step-over-step stair training is initiated.
That looks a lot better.
Unilateral static step training prepares the patient for more challenging single-limb balance exercises.
Also known as Captain Morgan exercise.
Combining lower and upper extremity activities challenge multiple systems and help prepare the patient for accomplishing a range of activities of daily living. The patient utilizes his improved strength and frontal and sagittal plane range of motion to successfully clear the obstacles. With the removal of upper extremity support and the addition of an external perturbation, the patient demonstrates poor balance and inability to clear obstacles. Ambulation training on uneven terrain improves the patient's dynamic balance and step height. The reciprocal movements of this warm-up activity help decrease rigidity and improve.
There's a new step for you guys. Finally got a picture of one.
Hip-trunk dissociation.
That's what he's using here.
Manual abdominal retinaculum releases counteract the stooped posture and assist the diaphragm to descend into the abdominal area, facilitating improved oxygen and carbon dioxide exchange. Next, the therapist releases the pectoralis, suboccipital, and lower extremity muscles using muscle energy techniques and stretching. Visual feedback is provided using a full-length mirror together with verbal and tactile cues to encourage neutral alignment and avoid stooped seated posture. The patient closes his eyes to internalize what neutral alignment feels like.
All right, now let's work on standing posture.
Verbal and tactile cueing is also used to promote a neutral standing posture. Again, the use of the mirror provides visual feedback. Lower extremity scales are used to facilitate equal weight distribution.
Lift your chest up off your stomach. Again, push down. Squeeze your shoulder blades together. Get your chest off your stomach.
The patient uses the seated dip machine to depress the scapulae while maintaining a chin tuck and lengthening the spine. Feeling the chest lift off the stomach as the shoulders move down and back cues the patient to maintain a neutral spine. The therapist encourages exaggeration of movements when changing position from sit to stand and to perform posture set prior to ambulating. Exaggerating movement is effective in reducing poverty of movement. Correcting stooped posture before initiating the first step helps reduce shuffling while walking.
Stand up tall.
I guess we're back in New York here.
Big, long, aggressive steps. 5 steps. I want you to count them out loud in a rhythm. You ready?
The therapist instructs the patient to verbally and rhythmically count his steps. This rhythmic self-cueing helps the patient exaggerate his movements and heightens focus on gait performance. Hearing his own verbal cues promotes learning of the new rhythmic pattern.
You're going to take nice, big, long steps. Count them out loud in a rhythm. And go. 1, 2, 3, 4, 5. Turn. Okay, you're going to reach back with both hands, and you're going to sit down, controlling it. Good. Excellent.
Proper weight shifting plays a key role in ambulating with a normal reciprocal pattern. The patient performs alternate step-ups with and without upper extremity support. The patient stands on a foam surface while throwing a weighted ball to different targets placed in a sequence.
Okay, what's that? What is this device called that he's using? A rebounder. Good. Just in case you encounter them, this is a rebounder, right? Because it's going to rebound the ball back at him.
It's on the rebounder. As he has difficulty planning and initiating movement, this exercise is an excellent way to challenge his ability to plan movement. Since the patient was an avid alpine skier, gait training with bilateral walking sticks is familiar.
Do it again. 1, 2, 3.
Note his improved stride length and reciprocal gait pattern.
Go forward 2 steps. 1, 2.
The patient works on changing directions and turning without hesitation, freezing, shuffling, or poverty of movement. It is important for him to focus on maintaining a normal base of support using proper weight shifting techniques and not crossing one foot over the other while turning. Having the ability to turn with a normal step height and move into sidestepping without loss of balance can help the patient learn to navigate his environment safely.
Lift your chest up.
What's she really doing with him?
Good.
Dancing. Yeah. Right? She just got paid to dance. Think about that for a second. I mean, really, I know that we have a hard job, but in reality, she just got paid to dance for however long, 20 minutes or whatever she was with that patient. Let's look at the last video of him.
After 9 weeks, the patient is able to independently transfer from sit to supine to sit. He uses the rolling technique to get in and out of bed. This has helped relieve the patient's report of low back pain.
Not completely, but...
The patient is currently able to stop and start on command without hesitation of movement, freezing, or loss of balance. He is ambulating with safe, large amplitude movements in all planes.
Watch him real quick. What are you noticing about his upper extremities with gait?
Without fear of falling.
No swing. Good. What's that doing to his energy use? There's a little better.
The patient is able to control his descent when transferring from stand to sit. He is setting his posture before initiating ambulation and taking long, exaggerated steps in this confined area by counting his steps in a rhythm. Note that he does not hesitate or freeze when ambulating through the doorway. Dual and multitasking activities, such as holding a tray with a cup of water while ambulating around obstacles, continues to be difficult for this patient. Note his slowed cadence, shuffling gait pattern, and instability. He currently ambulates using the rhythmic self-counting method, which results in improved heel strike, knee extension, stride length, trunk rotation, and reciprocal gait pattern.
1, 2, 3, 4. 1, 2, 3, 4.
For safety, the patient is still encouraged to use a cane for ambulating up and down steps. Notice how he effectively weight shifts and lifts his feet in a step-over-step pattern. The patient independently walks out of his front door using the cane safely. Note the multitasking required to open the door and ambulate down the steps. He has greatly improved in functional mobility and safety.
So just to let you guys know, because I know that you guys all live in Las Vegas, this stuff down here is called grass.
When the patient completes the training program, he will have the tools required to manage his condition and counteract the physical progression of this disease. The individualized home exercise program must be a lifelong endeavor. This means it needs to be incorporated into the patient's everyday life and encouraged by caregivers to be carried out successfully.
Were we in New York? Oh, no, New York. There we go. All right. I knew I recognized that accent. All right. So you could see the fascination in gait, right? Especially when he had that multitask where he had to carry the tray and walk. Man, that gait just was like baby steps, right? Baby steps, Bob, baby steps. But when he could use the cadence, right? I don't know for a fact, but I just kind of suspect he probably was ex-military because there was a lot of cadence to him there. I know he could be taught that, but that was definitely a more military cadence with his voice. Oh, we're losing people. Must be one of those days where the internet's just being goofy. So what did you think about that with his training? Did you see anything that intrigued you? Caught your eye? Are you burnt out? Yeah, good. All right. Did this really, I'm hoping this helped that you guys could actually see some real, I don't want to say live patients in the term, but real patients that have some actual, defects, right? So your book also has, and I'll post the links up for you guys for these videos. I didn't get a chance to post them earlier today. There's also a couple more CVAs that are up. There's a thalamic ischemic stroke, which is probably a big one. There's a patient with muscular dystrophy. That's actually that's a really good case. I used the case study before. But what it does is it gives you the ability to see a patient without having to be in the room with them and freaking out, right? Because I'm going to be honest, the first spinal cord patient I ever worked on, Mr. McKeever was terrified. I'm not going to lie to you. I was terrified because I'm thinking I'm going to break his spine. Well, it's already broken. I couldn't break it anymore. Right? It was funny. It was like, you know, he was more worried about me being worried about treating him than I was worried about him. It was really strange. Right? And we got through it together. He was a good guy. Ex-pilot. He was like, you know, let's just get through this together. I don't know what I'm doing. You don't seem to know what you're doing. Let's do it together. That made me feel really good. Right? CVAs were probably my most terrifying. Spinal cord scared me, but man, the first time you treat a CVA is something else. Just because you don't know what you're walking into. You could be walking into somebody like both the patients we saw today. You could be walking into somebody that's just a complete and utter hot mess. Are there any questions? It's like a box of chocolates. You're exactly right. You're not going to know what it is till you open it up. Jamie, do we have the tape for that? All right. Anyone else? Does anyone have any questions at all for today? I hope this helped. I mean, I was really looking through these case studies, and the case studies were pretty good. Now, the case studies do have some questions in the case studies that wouldn't hurt to look at them. I'm not going to assign them as homework. I'm not going to do anything like that because some of the questions in the case studies are more PT oriented and less PTA oriented, like talking about what would be a goal. Be good for you to look at, especially if you know you're going to see these type of patients, right? All right, so then I'm going to stop recording here. Good, that's what I wanted to hear. I'm going to stop recording.